Hello, testing.
Okay, I think we'll start off. I think we have got enough and more people, so we'll just get going. I have to
Yes, sir.
warn everyone that I'm feeling slightly ill, but I'll try my best to maintain the energy. So, Dr. Ronak, you can please proceed.
Yes, sir. Today's case presentation for testicular tumors. The- our patient is 29-year-old gentleman who is a laborer from Theni, Tamil Nadu, and he presented with the chief complaint of left scrotal swelling since 6 months and lower backache since 1 month. Uh, Patient presented with left scrotal swelling since 6 months, which was insidious in onset and progressively has increased to its current size of approximately described as 7 centimeters, but no history of pain or trauma, and no history of swelling in the opposite testes, and no history of swelling anywhere else in the body. No history of fever, night sweats, or weight loss. He complained of lower back pain, which is insidious in onset, dull aching, continuous, no radiation, and it is reduced with pain medication with no aggravating factors. The pain is since 1 month, and no history of cough, breathlessness, blood in sputum, no history of abdominal pain, distension, or yellowish discoloration of eyes, and no history of headache, vomiting, visual disturbance, no bone pains. His past history, no known comorbidities, no surgical procedures, or no history of treatment for any prior malignancies. His personal history, he's married with a 1-year-old daughter, mixed diet, bowel and bladder are normal with sleep, which is normal, and he has no known drug allergies and no known habits, no significant family history. So we have a 29-year-old gentleman who is married with no known comorbidities with progressive left scrotal swelling since 6 months and lower backache since 1 month.
Okay, I'll just
Sir?
stop you right there.
Yes.
So, right, this is the typical history that you tend to get for, any germ cell tumor, right? You get a testicular swelling, which progressively increases in size and lower backache. So let us now discuss all the various, points that can be asked in the history to you by the examiner, right? So let's take it from the top. Let's go to the history of, yeah, this. So, what is, in terms of germ cell tumor, what is the significance of duration of scrotal swelling?
So the duration can tell us how aggressive the germ cell tumor is, and it can also tell us uh, if it is truly a tumor or if it is not a tumor. And the duration is also important to give us an idea of how it is progressing, sir.
Yeah, so basically your answer should be in this case, if it is a drawn out history, say it is over, 6 to 9 to 12 months, right? Anything over 6 to 12 months, usually in terms of germ cell tumors, you're looking at a seminoma, right? So it has got a better prognosis. It's less aggressive, so the history is longer. But when you're talking about a quickly growing testicular mass, in terms of germ cell tumor, you're talking about a non-seminomatous germ cell tumor. Okay, so something aggressive like a choriocarcinoma, embryonal carcinoma, they have a history of less than 3 months, less than 6 to 3 months, right? So shorter history means more aggressive histology, most probably non-seminomatous, whereas longer history means it could be a seminomatous. Okay, so what is the you mentioned that there's no history of pain, right, for the scrotal swelling. Now, what is the most common presentation of a testicular malignancy?
Painless scrotal swelling, sir.
Yeah.
So
Yeah,
if
so you
it's
get a pain,
painful,
you get a painless scrotal swelling. If at all, sometimes you get a dull aching, dragging pain. But if it is painful, what could be the causes?
so if it is painful, it may it's unlikely to be malignancy. It could be like a spermatocele, or it could be like a hematoma. or it could be a hernia, indirect hernia,
Okay,
or
I'll just slightly interrupt you there. So you can get pain even in a malignancy. Okay, so pain is not an indicator of for everyone to note. It is not an indicator of malignant versus non-malignant. In setting of malignancy, you can get pain if there's bleeding, right? So, example, if you have a choriocarcinomatous component, there you can bleed, right? If you have an associated infection along with the malignancy, orchitis or epididymitis, you can have pain. If there's torsion of the testis, which is very rarely seen, in the presentation of malignancy, you can have pain, right? If there's rapid growth of the tumor, sometimes you might have an infarction of the arteries. There also you can have pain. And of course, advanced disease, right? If it's involving the scrotal wall, etc., there also you can get pain. So whenever you discuss, so examiner ask you what is the meaning of pain here. First, mention the causes in a malignant setting. Okay. Then talk about benign, because try to avoid benign as much as possible when you discuss when you present your case. So when you talk about pain, think of pain in context of malignancy. So there could be bleeding, especially in choriocarcinomatous component. It could be a coexisting infection. There could be torsion of the testis in the malignancy. There can be infarction if there's rapid growth, and also in case of advanced disease, for example, involving the scrotal skin. Now, you mentioned trauma. What is the significance of trauma in case of testicular malignancy?
so trauma, again, same thing, sir. Hematoma or any kind of uh, like any kind of triggering factor which could be causing the swelling and inflammation.
Yeah, so trauma, right? It basically, trauma is not causative for a testicular malignancy, right? Earlier there was evidence that it could be, but current evidence shows that it's not causative, but it can help in early diagnosis of the testicular malignancy. So it can draw attention to the swelling. So in contrast of malignancy, it can draw attention to the malignancy. Okay, so you had mentioned that there's no history of swelling in the opposite testis. Can you tell me the chance for developing, a
Uh,
contralateral testicular malignancy?
synchronous, synchronous.
Yes, yeah, overall.
It is very low, sir. Less than 10 to 15, less than 10%
Yeah, so you
approximately.
can
I'm
say it's
sure.
2 to 3% actually. Okay,
Yes.
so yeah, 2 to 3% is generally the value that's quoted. You can say anything less than 5%, but in the textbooks, 2 to 3 is quoted. And which side is, if with what side of testicular malignancy do you most commonly get a contralateral malignancy?
Sir, with what side, sir? Sorry, like right or left?
Yeah,
I'm not sure, sir. Maybe
the
maybe
right side.
left.
Okay, so it
So,
is the right side. So if you have a right side testicular malignancy, you have a higher chance of getting a contralateral than if you have a left side. Now I want to ask you, what is the possibility of germ cell in situ neoplasia in the contralateral testis in case of a testicular malignancy?
so
We know that
I'm
germ
not
cell
sure.
in situ neoplasia is a precursor lesion, right? For your germ cell tumors. So I'll just tell you, you have a 5% chance. Okay, if you have a testicular malignancy in the contralateral testis, you have a 5% chance for GCIN. And what is the significance of GCIN? What is the risk of conversion to malignancy if you have GCIN at 5 years and at 70 years?
Not sure, sir.
Yeah. So GCIN, if you get it, you have a 50% chance at 5 years and you have a 70% chance at 7 years. Okay. Um, so they tend to ask that, very commonly asked. Okay. So why did you ask for history of swelling elsewhere in the body?
So to know if it is metastatic or if it is like a lymphoma, we to rule out.
Yeah. So we are
Uh,
mainly, like you said, there's two reasons. If there's metastatic disease, example to the, inguinal nodes or the supraclavicular node, etc. Also lymphoma, right? In case of lymphoma, you get, nodal swellings elsewhere in the body. And we all know that testicular lymphoma is also a diagnosis that can be seen. Now, what about fever, night sweats, and weight loss?
So again, lymphoma, tuberculosis of the testis,
Yeah.
or any kind of infection, chronic infection, STDs, like
Yeah. So,
maybe.
lymphoma. Okay. So, like I said before, restrict your answer to malignancy. The moment you bring in non-malignant conditions, right, the examiner gets all worked up. They generally tend to. So, like you mentioned, you gave the right answer. It is lymphoma. Definitely, we are looking for B symptoms, right? And
Yes,
if
sir.
they ask you non-malignant causes, definitely you can list it out, but stick to malignancy for the time being. Okay. So now getting into the rest of it. So what are B symptoms? Can you define B symptoms? Uh,
So B symptoms
yeah. Can you define
are
B symptoms?
B symptoms are symptoms which are not directly related to the compression of the cancer directly, but it is related to inflammatory kind of
Yeah.
uh,
So
i- i-
you have fever, night sweats, and weight loss. How do you define fever, night sweats, and weight loss in context of B symptoms?
so fever, night sweats, and weight loss are B symptoms. Like they, I'm not sure, sir. Like
Yeah, so I'll give it. So when they ask you, can you define B symptoms? You say fever. Fever is the first one. So a temperature of greater than 38 degrees Celsius or greater than 100.4 degrees Fahrenheit, right? Which persists for greater than 2 weeks. That is not explained by any other cause, right? Night sweats you tend to get, which is not explained by any other cause and persists for greater than 1 month. And weight loss is if you have a greater than 10% loss of weight within less than 6 months. Okay. So all which is not explained by any other cause. So all these points should be noted there. I hope everyone got it. So note down all the points for various like fever, night sweats, and weight loss. So when they ask you to define B symptoms, mention it like that. Okay. What this lower backache, right? Lower
yes, sir.
backache, right? What is the significance there in case of a germ cell tumor?
So that is a referred pain because embryologically testis is like testis arises from the lumbar
I,
region,
I will
lower
ask you, I'll give you, what is the most common site of metastasis in a testicular malignancy?
para-aortic lymph nodes,
Yeah, so
uh,
not paratic as such, but retroperitoneal lymph nodes. Okay,
retroperitoneal. Yes, sir.
retroperitoneal lymph nodes. Okay, so for the left side, what is the most common retroperitoneal node, and for the right side, what is the most common retroperitoneal node?
Not so para-aortic nodes
Yeah, yeah. So for
or
left side, it is para-aortic node, and for right side, it is inter-aortocaval node. Okay, and uh, can there be crossover? As in, can there be spread from right to left nodes or left to right nodes?
it could be, sir, but still unsure.
Yeah, so like I said, left side is paratic node, right side is interaortocaval node, and spread can usually occur from right to left, but not from left to right. Okay. And one more point to note here is that from these retropetal nodes, it spreads via the retrocrural, nodes to the posterior mediastinum. Okay. So it spreads to the posterior mediastinum, and it can also extend via the thoracic duct to the left supraclavicular fossa. So they ask you the nodal spread of GCTs. This is what you should say. The retropetal nodes, left side para-aortic, right side interaortocable, then through retrocrural nodes to the posterior mediastinum, and also through the thoracic duct to the left supraclavicular fossa. Now, what is the rate of primary retroperitoneal GCT? As in primary, no, there's no testicular mass, but primary origin is in the retroperitoneum.
Not sure, sir, of the
Yeah, so
status.
it is around 1 to 3%. Okay, it is very rare. Um, okay, we'll move on to the next slide.
Yes. So HOPI, sir, no history of cough,
Yeah, you had
breathlessness.
mentioned that. I'll just ask you the significance. Okay, so cough, breathlessness, and blood in sputum. What are we looking at here? What are we trying to elucidate in terms of disease?
Pulmonary metastasis, sir, if
Yeah,
there is any
yeah.
pulmonary
So we know
metastasis.
that. So like we're going in a sequence, right? So testicular mass will first spread to the retroperitoneal nodes. Another area where it commonly spreads is the lungs, right? So of course, this could indicate spread to the lungs. It can also indicate you know so lung mets is what we're looking at here. What are some of the tumors where you get the histologies of germ cell tumor where you get lung mets before retroperitoneal spread?
So choriocarcinoma is very common, and it is not even a poor prognostic factor to have lung mets in choriocarcinoma,
Yeah.
or
So
even
you have
non-cell.
two histologies. Okay, you have embryonal and choriocarcinoma. Both these histologies, you can have skipping of the retroperitoneal nodes, and you can have direct lung mets. Okay. Now I want to ask you something. You can also get these symptoms if you have a mediastinal metastasis, right? So if it metastasis to the mediastinal nodes, also you can get cough and breathlessness. So I want to ask you, what is the chance for a primary mediastinal germ cell tumor? As in, there's no testicular mass, but only primary mediastinal disease. What is the risk?
Around it is a poor prognostic factor, and it is around less than 10%
Yeah,
chance,
so it
up to
is
15%.
it's smaller than that. It is up to 5%. Okay. So up
Yes.
to 5% of GCTs are primary mediastinal. Now, can you tell me what is the difference in location between primary mediastinal GCT and metastasis to the metastatic disease to the mediastinum? What is the difference in location?
Location, as in, sir, like
Which part of the mediastinum is involved in these two settings?
I'm not sure, sir.
Yeah, so primary mediastinum is generally to the and it's located in the anterior mediastinum. Okay. Whereas secondary mediastinum, that is mediastinal nodal mets, is to the posterior mediastinum. So that is the difference. And so mediastinal, so outside of the testis, most common is mediastinal, primary mediastinal disease. Second most common is retroperitoneal disease, and the third most common, very rarely seen site, is primary brain GCT. Okay, so that's seen in the sella area as well as the pineal gland area. So that is also another uh, area where primary GCT is seen. Okay, so now you have some other negative histories. For example, liver mets. You have elucidated the abdominal history, headache, vomiting, visual disturbances for brain metastasis, most commonly seen, especially in choriocarcinomas. And you also have bony pain. Bony pain, bone mets are rare, but it is more commonly associated with seminoma. Okay. So can we go to the next slide, please?
Yes.
So what is the history of prior surgical procedures here? Can you quickly
So,
summarize what we're looking for here?
so in prior surgical procedures, if we're looking for hernia or any recurrent hernia, or like has he had any kind of surgery with a scar, with a high inguinal scar or a low inguinal scar, like those things, we just want to rule out if there is anything relevant, sir.
Yeah, okay. So definitely, I'll get to one point that you mentioned, but overall, if you're to when you're asked this question, this is how you answer it. So number one is orchidopexy. Okay, we know that cryptorchidism is a risk factor for testicular malignancies. There's a relative risk ratio of around 4. Okay, so usually cryptorchidism, people have a history of orchidopexy. Okay, now there are a few things that you need to know about orchidopexy. First of all, uh, first of all, let's look at cryptorchidism. They can ask you the normal descent of the testes. Okay, so how, at what point, at what period, at what location the testis is found at. So in the second month of pregnancy, you have the beginning of the descent of the testis. At the third month, it reaches the iliac fossa. Around 4 to 6 months, it reaches the deep inguinal ring. At the eighth month, it reaches the superficial inguinal ring, and at the ninth month, it reaches the scrotum, right? So that is the descent of the testis normally during a pregnancy. Now, orchidopexy is usually done after greater than 6 months. The reason is that less than 6 months, 80% of the patients have normal descent of testis. Okay. So it is done greater than 6 months. So we wait for 6 months after birth to see if it will normally descend. If not, usually do it greater than 6 months up to 1 year. Okay. So that is maximal risk decrement for testicular malignancy is done if you do orchidopexy early, that is greater than 6 months up to 1 year. The risk still decreases if you do it up to less than 6 years. So you can get away, you can cause a decrease in relative risk of developing GCT in cryptorchidism if you do it up to 6 years. Okay. Now, beyond that, there might not be a decrease in relative risk, but you still do an orchidopexy. Okay, so even if you're not done an orchidopexy, the cryptorchidism, and it's past 6 years, you can still do it. What is the reason for that?
Sir, reason for beyond 6 years,
Yeah, we
if
know that the
the
benefit is usually from 6 months to 1 year, and it can extend up to 6 years, right? It can decrease the risk, but beyond 6 years, there might not be. So, what is the reason for doing an orchidopexy beyond 6 years?
so if it is a because if it is not descending, then it's unlikely to be functional anyways, the testis.
Yeah. Yeah. So
And
the answer there is we do it to, if the patient detects, develops testicular malignancy, we need to detect it early. Okay. So for early
Yes.
detection, that is the main reason why we do an orchidopexy past 6 years, even though there might not be much benefit in terms of risk reduction. Okay. Then, like you mentioned, transscrotal pelvic surgeries, right? If there's any previous history of those can alter the nodal drainage. So you might get inguinal and pelvic mets if the scrotum has been breached or if various pelvic surgeries have been done. And of course, you're looking for a previous history of orchidectomy if the patient had a prior history of a testicular tumor. Okay. So that's why you look for surgical procedures. Um, now, history of treatment for prior malignancies, of course, the main cause could be a contralateral testicular GCT that could have been treated earlier. Okay, so that's number one. Then this germ cell tumors are also part of many syndromes where you get other malignancies. Okay, so you have this testicular tumors are part of many syndromes where you also get other malignancies. For example, Klinefelter syndrome, you might have a lymphoma or leukemia. For Peutz-Jeghers syndrome, you have Sertoli cell tumors where you have a colon cancer, etc. For von Hippel-Lindau disease, you have papillary cyst adenoma of the epidermis, which is associated with a wide range of malignancies, right? And for FAP, you have sex cord tumors, which are associated with CA colon and other malignancies. So these are some, uh, you know, uh, syndromes in which you get testicular malignancies, which are associated with other malignancies. So that is something there. Of course, the number one history you're looking for is history of treatment of the contralateral testis for a testicular tumor earlier. Please move on.
Yes, sir.
Yeah, let's go to the personal history. So always mention this in your personal history. Look for whether the patient is married and look at whether they've completed their family or not. Okay, because that has implications in terms of fertility counseling. Okay, now let's go on to the family history.
So,
Okay, so in family history, you look at the risk if a particular family has got a germ cell tumor. Okay, so if the brother has got a germ cell tumor and if the father has got a germ cell tumor, what is the relative risk
it will be
for brother
uh,
and father?
so it will be high, sir. But like relative risk will be 6 to 8 times, approximately, maybe.
Yeah, so you're around the ballpark. So for brother, it is slightly higher. It is 8 to 10, right? For father, it is slightly lower. It is 4 to 6. Okay. Now, for twins, it is much higher. So monozygotic twins, it is greater than 50. It can extend up to 75. Okay. And for dizygotic twins, it's slightly lesser. It's 30 to 40, increased relative risk. So they very commonly ask this. Now, I want to just ask you, what is the most common chromosome abnormality seen in testicular tumors?
So maybe Klinefelter's. Uh,
I mean, overall, this is a pathognomic feature that is seen in GCTs.
so 40,
Yeah.
47.
So it is isochrome 12p. Okay.
Oh,
Isochrome 12p. This is also asked. So can you just list out quickly as many risk factors as you can? So we have discussed some of the risk factors. Can you list out quickly as many risk factors as you can for a germ cell tumor?
so family history, then if there is any prior undescended testis is one of the highest risk factors. Then any cryptorchidism, same like, and then one previous testicular malignancy. Then any radiation to the testis, um, any kind of isochrome 12, and then if they have any. Uh, so that's all I can think of.
So I'll just quickly go through it. Cryptogordism, like we discussed, family history for you should know the relative risk for brother, father, and twins. Testicular dysgenesis syndrome. Okay, so that consists of cryptogordism, hypospadiasis, and infertility. So there also you have increases for testicular malignancies. Then marijuana use. Okay, so that is also seen in certain studies to have an increased risk. Genetic causes like Klinefelter syndrome, Noonan syndrome, and Down syndrome. For example, in Klinefelter syndrome, you'll get a mediastinal GCT. Okay. Then, so that's also another cause for germ cell tumors. Then you have, previous history of testicular malignancies puts you at an increased risk. And of course, you have various infections like HIV, for example, where you have an increased risk for testicular malignancy. Okay. So now moving on. Okay.
So end of history, sir.
Yeah,
29 year.
I'll just discuss one more thing before we get into the DDs. Okay.
Yes,
So in India, what is the incidence of germ cell tumors?
instruments. it's
So
relatively lower, sir.
yeah, so you're right. It is lower. It is 0.3 per 1 lakh population. Okay. It is 29th position, in fact. But in Scandinavian countries, it is significantly higher. What has been the, this is for extra marks, okay, for those who want to top. What is the possible reason for higher prevalence in Scandinavian countries?
Some less sunlight, maybe.
Yeah, so they have given a genetic cause, it's given in Devita. So c-KIT ligand is highly expressed in the Scandinavian population, which leads to higher development of testicular malignancy. Okay, c-KIT ligand. Okay, so that is something they can ask you. Now coming to the differential diagnosis. Okay, so can you go to the summary slide, please?
Yes, sir.
Okay, so
Yeah, yes, sir.
based on this, what will your DD be?
So, a 29-year-old gentleman with no comorbidities, and it is a progressive left-sided scrotal swelling of 6 months with lower backache. We would definitely have some differential testicular pathology. In the testicular pathology, it could be either seminomatous, non-seminomatous, or like embryonal teratoma,
Okay. So,
like
so I'll tell you how to proceed. When they ask you the DD after history, right? Just mention that it has a a progressive long history and it's associated with lower backache. So I'd like to give a probable DD of a testicular malignancy. So at this point, that's all you can say. Okay. There's no need
yes.
to further subcategorize. Just mention DD of testicular malignancy. Okay. At this point, this is something that the examiner will commonly ask you. What are the differential diagnosis of a testicular tumor by age? This is a given question, okay? And if you can have an answer ready, I will prepare it. I'll tell you what all to say at what all age. Keep this answer ready. It will be very useful in exams. So if you have a neonate or an infant, right, it is usually granulosa cell tumor. Between the ages of 1 to 20 years, you can have an acute leukemia, right? An acute lymphoblastic leukemia, or a paratesticular rhabdomyosarcoma, or sex cord tumors, or you have something called a prepubertal yolk sac tumor, or a teratoma, or a prepubertal teratoma. So neonates or infants, it's granulosa cell tumor. 1 to 20 years, it is ALL, paratesticular RMS, sex cord tumors, and prepubertal yolk sac tumor and prepubertal teratoma. Okay, so that is the DDs there. Now, between 20 to 30 years, that's when you get your non-seminomatous tumors most commonly. Okay, so 20 to 30 years, non-seminomatous tumors. Then later on, 30 to 50 years, that's when you get your seminomatous tumors. Now, greater than 50 to 60 years, these are the DDs. So you get lymphoma, that is the most commonly seen testicular malignancy at that age. You get, what is the most commonly seen lymphoma? When it presents as testicular.
ALL. ALL.
So it is DLBCL, okay?
Okay, sir.
Diffuse large
Yes.
B-cell lymphoma.
Sorry,
So
lymphoma. Sorry,
yeah.
sir. Yeah.
So greater than 60 years, lymphoma is most common. Most common histology is DLBCL. You can also have Mets from the prostate, from RCC, from a melanomatous lesion. You also see spermatocytic seminoma, okay? And you can also have a primary testicular sarcoma as well. So those are the common causes beyond the age of 50 to 60 years. Now, another thing to note here is that they might ask you the management of some of these malignancies. So, what is the management of an paratesticular RMS?
Rhabdomyosarcoma, we would RMS. It is usually we'll have to try the regular
Yeah,
rab,
someone mentioned one more. Sorry for interrupting you, but greater than 50 to 60 years, you're right. You can also have a primary testicular plasmacytoma. So, just for completion's sake, include that also in greater than 50 to 50, 60 years. Yeah, please continue.
Sir, RMS again, we will have to go for that ICE kind of, meaning we'll have to do the sarcoma panel only, so IFAS area and IA or IE, VAC,
Yes.
IE,
So,
like
that is your, I think you're talking about treatment for Ewing. So in paratesticular RMS, use the IRS protocol. Okay. So that consists of VAC. So that is vincristine, dacnomycin, and cyclophosphamide. Okay. So that is what is usually given. And in paratesticular RMS, it has a high propensity for nodal mets. Okay. So you do a high inguinal orchidectomy and you look at the age of the patient. So if the age of the patient is less than 10 years, you can, get away with observing. If the age of the patient is greater than 10 years, there's a large risk for mets to the retroperitoneal lymph nodes. So there you do an ipsilateral retroperitoneal lymph node dissection. So high inguinal orchidectomy, and if greater than the age of 10 years, you do a ipsilateral retroperitoneal lymph node dissection. And following surgery, you treat with VAC for up to 1 year, right? So the IRS protocol with VAC regimen. Now, coming to lymphoma, DLBCL, right? What is the treatment here? Once again, you do a high inguinal orchidectomy. Following that, you give, for example,
R-CHOP.
yeah, you give R-CHOP into 6 cycles, and this testicular malignancies, DLBCL has a high propensity for brain mets. So you also give ITMTX. Okay. So you give high inguinal orchidectomy, R-CHOP with ITMTX. Okay. So that is the treatment there. Then spermatocytic seminoma, what is the treatment?
Spermatocytic seminoma. It is a seminoma only, sir. BEP.
Oh, no. So this is the trick question. It has got a much better prognosis. Although the name suggests seminoma, you only do a high inguinal orchidectomy. Okay. So
Yes.
only high inguinal orchidectomy is done if you get a spermatocytic seminoma. Now let's go to the differential. So that is this list that I've given you is very important. Always remember this. Now, when you go for you can give differentials based on the rapidity of symptoms. Okay. So if you have symptoms less than 1 month history, these are the DDs that you think of. DLBCL Burkitt's. Okay. Primary testicular DLBCL Burkitt's. It could be an ALL involvement that can progress rapidly. You can have non-seminomatous tumors like choriocarcinoma and embryonal carcinoma, which also progress very rapidly. And you have a sarcoma like RMS or others if they are older, RMS in younger and others in older, which can also progress rapidly. So those are the DDs for a testicular lesion, say progressing in less than 1 month. Okay, which are very aggressive. Okay,
Yes.
now can you tell me the classification of testicular tumors?
So testicular tumors we will classify into seminomatous and non-seminomatous and dysgerminoma and embryonal type. So if it is seminoma, it's different. But if it is non-seminomatous, then we would see if it is a dysgerminoma or embryonal carcinoma. In embryonal carcinoma, meaning embryonic structures are there.
Yeah.
So if there are, if it is embryonic structures, then it is a teratoma. In a teratoma, based on the type of embryonal structure, if
Yeah,
it
so
is
you
a
can just mention the types. You need not go
mature,
into what they contain, right? So
mature, immature, and specialized
yeah,
teratoma, sir. And in if it is an extra embryonic structure, that is not the embryo, then choriocarcinoma or yolk sac tumor. We could see, sir. Otherwise, dysgerminoma is undifferentiated non-seminomatous germ cell tumors,
yeah.
and then we have seminoma, sir.
Yeah, so I'll just quickly classify that. You have right you can divide when you get asked this question, you can first mention the germ cell tumors. So germ cell tumors are the most common, right? In males, 95% are germ cell tumors. Germ cell tumors can be classified into those that arise from germ cell in situ neoplasia and those that do not arise from GCIN. So those that arise from GCIN include seminoma, then non-seminoma. Non-seminoma is divided into yolk sac, embryonal, teratoma, and choriocarcinoma. Now, those that do not arise from GCIN include prepubertal yolk sac tumor, prepubertal teratoma, and spermatocytic seminoma. Okay, so those three do not arise from GCIN. So that is germ cell tumors. Second is your mixed tumors, which is a mixture of seminoma and non-seminomatous, right? Here, I like to point out that seminoma is the most commonly seen histology, followed by mixed. Okay, then coming to sex cord tumors, you have your Leydig cell tumor, your Sertoli tumors, and your granulosa cell tumors. Okay, so
Yes.
and then you have your miscellaneous tumors like lymphoma, sarcoma, etc. Okay, so this is the general classification. Germ cell tumors, you divide them arise from GCIN. Those that do not arise from GCIN, then you have your mixed. Then you have your sex cord tumors. Then you have your miscellaneous tumors. Okay. Now, coming to we can continue with the case now.
Yes. So now we go on to general physical examination. So now the patient is conscious and oriented with ECG performance status of 2, and his vitals were stable, but his BMI is 18, slightly on the lower side, and no pallor icterus edema, and no body dysmorphic features, and no gynecomastia. On local examination,
So
patient
in
was
a general physical examination, I'll just point out a couple of things. Okay. So you should know your ECOG and KPS score, performance status. That is a given. What is the significance of increased pulse rate and hypertension here?
so then it could indicate some a secretary kind of do we have extremely high beta HCG, which could also mimic thyroid hormone,
Yeah.
or beta HCG, which could mimic some of the hypothalamic cortisol.
Yeah.
So beta
So beta
HCG
HCG
shares
can,
a
you're right. Beta HCG can mimic, your thyroid hormones, and it can lead to increase in pulse rate and BP, and that is most commonly seen in choriocarcinoma. Okay. So what about body dysmorphic features? We're trying to exclude, like Klinefelter syndrome. So if they ask you what you see in Klinefelter syndrome, it's XXY, taller. The patients are taller with longer limbs, ill-defined secondary sexual characters, and delayed puberty. Now, what are the causes of gynecomastia in a germ cell tumor or in a testicular tumor?
was sex called stromal tumors, especially if we are talking about some ladies, or if we are talking about
Okay, that's fine.
granulous, something which has hypoestrogenic state, uh, and those gynecomastia is pathognomic for something mostly sex called stromal kind of tumors.
Yeah. So, causes of gynecomastia, you'll start off with tumors that secrete increased beta HCG. Okay. So, that can also cause gynecomastia. So, beta HCG is seen in choriocarcinoma, embryonal carcinomas. Okay. Then,
Yes,
it can be a part of testicular feminization syndrome or testicular dysgenesis. Okay. So, testicular feminization syndrome is very commonly seen in germ cell tumors, and there also can get associated gynecomastia. Now, Leydig cell tumors or sex cord tumors, like you mentioned, can secrete estrogen, and it can also be a part of associated Klinefelter syndrome as well. Okay, so these are the most common causes for gynecomastia in a testicular tumor. Now, let us go on to the examination. So please proceed.
so local examination, the patient was examined first in standing position and then in supine position after exposing from nipple to mid-thigh. And on the inspection, his right hemiscrotum appears normal, but left hemiscrotum, there is a swelling with the 7 into 6 centimeters globular shape. Swelling is seen in the left hemiscrotum, and on lying down, the swelling does not change, it does not reduce, or it does not go back inside. And on cough impulse, it doesn't change. And then there are no scars and sinuses. And normal scrotal skin is like maintained, and there is no penile deviation. That is on inspection, sir. Then on palpation, there is no tenderness and no local rise in temperature. The right hemiscrotum again is same, and with the 4 into 3 centimeters testis, which is smooth, and there are normal testicular sensations. And the right spermatic cord at the base of the testis was not enlarged, and the swelling in the left hemiscrotum is almost double in size to the normal right testis on comparison. And this is now globular and hard in consistency with a smooth surface, and he doesn't feel pain on palpation. And the swelling cannot be differentiated from the left testis. The sensations are all preserved, the swelling is non-reducible, and cough impulse is negative. There's
He
no
also mentioned getting above swelling is possible. Okay, that is very important. We'll discuss why that is important.
yes, sir. Non-reducible and getting over. So, yes, sir. And no cough impulse, and the left spermatic cord is not enlarged, and there are no palpable lymph nodes. Yes, sir. That's the end of
Yeah.
palpation, sir.
So,
Uh,
this is, can we go back one step? Yeah, one more slide. So I have mentioned here inspection and palpation in a setting where there is a testicular mass present. In your exams, all these points that are mentioned, you will get into what those imply. All these points that we have mentioned here are very important. You should write them in your answer sheet. Okay. But in certain scenarios, in certain centers, you might get a patient that has already undergone high inguinal orchidectomy. And if they present to you like that, then we'll discuss what you should write in inspection and palpation in a patient post high inguinal orchidectomy. So please mention that.
Yes. Uh, if the patient has a high inguinal orchidectomy, then on inspection there will be no testicular bulge, and right hemiscrotum will show the normal testicular bulge, and the scar will be seen in the left inguinal area, and the scar will be about 7 centimeters, and there will be that will be the main single scar usually, and the skin and everything will be normal, and there will be no testis, left testis, because of that. And then when we palpate a patient post inguinal orchidectomy, uh, there will be no tenderness, and there will be no testis, and the spermatic cord also will not be palpable. But the right testis will be palpable, and the right testis is not like it will be normal, and there will be no spermatic cord enlargement, and there will be the scar will be palpable in the inguinal area, and there will be no cough impulse, and there will be no induration or swellings in any inguinal nodes, and there will be no any other findings.
Okay, so when you get a case with post-hyoidal orchidectomy, these are the histories that you should write. So just note down all these points, and it can guide you on how, what to write in your answer sheet. Okay, so I just put that in there because that is an alternate scenario that many of us encounter. In that case, we might, suddenly not know what exactly to write. So that's why I put that there. Okay, so coming to the end, this is definitely, like we have mentioned before, this looks like a testicular malignancy, right?
Yes,
And
sir.
on examination, if the points that could point towards a testicular malignancy is if testicular sensation is lost, if it is non-reducible, right? So that implies it's not a hernia. If you're able to get above the swelling, right? If there's absent cuff impulse, all these features point towards a malignancy. Okay. And inguinal nodes in this setting, we have also mentioned in palpation, you can get if there's scrotal violation, either with a biopsy or transscrotal surgery. And also you can get in certain large lesions. So if there's a large testicular mass, that might spread to the inguinal nodes, especially if there's scrotal involvement, right? So those are the features seen there. Now, they'll also ask you something here. What is the normal size of a testis? So that is around 5 into 4 into 3 centimeters. Okay. So that is also something they'll ask. You should know what the normal size of a testis is. Okay. So coming to the DD, we have come to a testicular malignancy, a primary testicular malignancy probably. So they can ask you at this point what type of testicular malignancy it could be. So you should mention here that most common is germ cell tumor. So I'm suspecting a germ cell tumor. Then I'll ask you what type of germ cell tumor. There you should say that this patient is um, he's in his 20 yeah, so
29.
he's 29 years old, and there's a slightly shorter history, 6 months and less of testicular swelling. So this could more likely point towards a non-seminomatous. If it is greater than 35 years of age, if the history was more than 6 months extending up to 12 months, there you can think of a seminoma. So based on that, you can move towards each side. Okay, either seminoma or non-seminoma. So I hope you got that. Now, once you've established this, the next line of questioning will be the workup. Okay. So what will you do first when it comes to so like I said, for the previous case presentations I mentioned, workup is spoken about under 3 headings, right? The workup for diagnosis, workup for staging, and workup for treatment, right? In some malignancies like testicular malignancies, the workup for diagnosis and staging are combined together. They intermix with each other. For some, it is in a sequential manner. So it depends on the malignancy. But in this case, but we should still talk under these 3 headings. Okay. So I will just quickly, since we have a lot of points to discuss, I'll just quickly go through the workup. Number 1, you do a transscrotal ultrasound. Okay, a transscrotal ultrasound, and most commonly, these are the features you'll see in seminoma. Seminoma, you'll see a hypoechoic mass, which is homogeneous, which has increased vascularity, and which has associated microlithiasis. Okay, so hypoechoic and homogeneous mass. With non-seminoma, you'll see a heterogeneous mass, right? Which can vary depending on the type of non-seminomatous tumor. You'll also see cystic areas and areas of calcifications. Okay, so that is very commonly seen in non-seminomatous tumors on a transscrotal ultrasound. So once you've done your transscrotal ultrasound, your next important thing will be to do the markers. So here you do beta HCG, you do AFP, and you do LDH. Okay, these are the three markers that you do. Now, what is the half-life of beta HCG?
So 1 week.
Yeah. So beta HCG is 24 to 48 hours. Okay.
Okay.
AFP is 7 days or 1 week. And LDH is 4.5 days. Okay. So you should always remember the half-life of all these markers. Now, another question they'll ask you regarding beta HCG is what is the prozone effect, right? So sometimes with beta HCG, what you'll tend to have is if the beta HCG is very high, for example, more than 5 lakhs or 1 million, right? It might falsely show as a low value. That is because the antibodies which test beta HCG on testing are overwhelmed by the increased beta HCG, so they do not bind appropriately to beta HCG. Because of that, you get a false value, falsely low value. That is called the prozone effect. Okay. Now, you also have false rise in beta HCG that is seen if the patient is taking marijuana, if you have hypogonadism states, right? In those cases, you get decrease in beta HCG. Another question they'll ask you is what is the normal value of beta HCG and AFP? So normal value of beta HCG is generally less than 5, and the unit is also very important. Milli international units per ml. They'll also ask you that. AFP is usually less than 10, depends on the center, but the unit is nanograms per ml. Okay. Now, another important question they'll ask you here is what tumor is associated with what elevation in the tumor marker. So yolk sac tumor is associated with increase in AFP and LDH. Embryonal tumors associated with increase in AFP and beta HCG. Choriocarcinoma is associated with increase in beta HCG. And seminoma is associated with normal AFP. Seminoma, the AFP is always normal, right? And HCG can be raised in only 15% of the cases. Okay, in case of a seminoma, AFP is always normal, HCG can be raised in 15% of the cases. Yeah, so yolk sac tumor is AFP and LDH, embryonal tumor is AFP and beta HCG, choriocarcinoma is HCG, seminoma is normal AFP. In some 15% of cases, you can get a raised HCG. Now, the range of HCG is also very important. They can ask you, suppose the HCG is a particular range, what could it imply? Right? So I'm just going through all possible questions here, like so that every base is covered for you for these practical exams. So seminoma, you get a beta HCG range of 50 to 500. Embryonal, you get a beta HCG range of greater than 500. And choriocarcinoma, you get a beta HCG range of greater than 1000. So if the values, although this is not completely accurate, but as a rule of thumb, if the values are in these ranges, you can suspect these GDs. Okay. Now, it is very important here that we do further imaging, right? So you have done your transscrotal ultrasound, you have done your markers. Now you need to do imaging. What is the imaging that we'll do?
CT, so FTG PET CT, we can do MRI also, but FTG PET is usually it's highly sensitive.
So I asked this question. I'll just tell you what the answer should be. Okay. So ideally we'll do a CT thorax, abdomen, and pelvis. Okay. There is no role for PET CT upfront. Okay, so that is very important. In testicular GCTs, there's no role for PET CT in the upfront setting. So you'll do CT, thorax, abdomen, and pelvis. Now, coming to the role for MRI, it is not done in all cases. It is done in certain scenarios. For example, these are the conditions where this is another question they can ask you. If CNS symptoms are seen, for example, headache, nausea, vomiting, blurring of vision, you can consider doing it. If beta HCG is greater than 5,000, this is also mentioned in NCCN, if beta HCG is greater than 5,000. If you have extensive non-pulmonary visceral mets, so if you have liver mets, if you have bone mets, etc., and there's a high chance for brain mets as well, in those cases, you can do an MRI brain. If the AFP is greater than 10,000, okay, so that is also another indication. If the AFP is highly raised, and if you have in the biopsy, right, which comes later on, if you have a significant choriocarcinoma component, there's a high chance for brain mets. So there also you should do an MRI. So CT thorax, abdomen, pelvis, MRI in certain settings, no role for upfront PET CT. Okay. Now, you will, of course, 5,000, beta HCG greater than 5,000. Okay. So now the next thing that you'll do, so you have done your transscrotal ultrasound, you've done your markers, you've done your imaging. You will discuss, you should say it like this in the exam. You'll discuss this case in a multidisciplinary tumor board. Okay. That should always come across. And you should also say that if the person is stable, what should we do? We'll go for a high inguinal orchidectomy, right?
Yes.
Yeah. So that is the standard of care. Why a high inguinal orchidectomy? Can you perhaps give me one or two reasons?
So the thing is, we cannot biopsy these tumors, and there will be spillage. So, and the tumors through the spermatic cord itself, we will have to retract and pull it out. So that's why we would go for a high inguinal approach, because the transscrotal approach is not favorable, and there will
Yeah.
be
So you
leakage.
mentioned one of the reasons. So I'll just give you the full list of reasons, right? So first of all, you need to establish that you have negative margins for the spermatic cord, because these tumors can spread through the spermatic cord. So to establish proper negative margins, you need to do a high inguinal orchidectomy. Now, number two reason is that the testis is a sanctuary site, right? So chemotherapy may not adequately penetrate the testis. So you always need to do a high inguinal orchidectomy to remove the testis and the spermatic cord, both of which might not receive chemotherapy in enough concentration to have its effect. Then, like you said, to avoid spillage of tumor, right? So to prevent that, you do a high inguinal orchidectomy. So these are the three reasons why: negative margins of spermatic cord, testis and spermatic cord is a sanctuary site, and to avoid spillage of tumor. There's something also known as a low inguinal orchidectomy, which we don't commonly use for testicular tumors, where we do the incision at the external iliac ring below. High inguinal orchidectomy is done at the what do you call the internal iliac ring. Okay. So now the procedure is usually a 5 to 7 centimeter incision around the pubic bone, right? And you use non-absorbable so you remove the testis with the coverings intact along with the spermatic cord, and you incise the spermatic cord above at the deep inguinal ring, right? So that is all these steps are very important. So then you use a non-absorbable suture to tie up the spermatic cord so that it can be identified later on. So that is another thing that we do there. Now, another question they can ask you is, what are the components of the spermatic cord? So you need to say the vas deferens, the arteries, the cremastic and testicular arteries, the papniform venous plexus, the nerves, including the genitofemoral nerve and the sympathetic nerves, as well as the lymphatics, right? So all these are components of the spermatic cord. They can ask you this over here. Now, very important, we need to know the indications for a contralateral testicular biopsy. Okay, it's not given in the textbook, but this is something that they can ask you in the exam. So indications for contralateral testicular biopsy include if the patient is less than 40 years of age and has a low testicular volume of less than 12 ml. Okay. If the patient has a history of cryptorchidism, which has not undergone orchidopexy, that is another indication. If the patient has low sperm count in an atrophic testis, that is another indication. Or if the person has microlithiasis, there also we can consider doing, right? So all these features, if seen, we can consider doing a contralateral testicular biopsy. Consider doing is the key word here. Now, if we do it,
Sorry,
ah,
sorry, it will be punch biopsy, or we'll have to
yeah.
remove
So
the.
yeah, that's a good question. We're getting to that. So if you're doing a contralateral testicular biopsy, use something called Chevasu's manure. Okay. So you remove the the testis along with the coverings. You remove it outside the scrotal sac, and then you do the biopsy, and then you return it back to the scrotum. Okay, that is called Chevasu's manure. It's to prevent spillage of the tumor, right? It's to do it in a safe way, right? So that's that. Okay. Now another question they can ask you here is that indications for omitting upfront surgery. Okay, so sometimes you might not be able to do upfront surgery because the patient is not fit enough, right? So in those cases, for example, if you have a high beta HCG, if the patient is so high beta HCG, there's a high chance for bleeding, right? Especially choriocarcinomatous components, there's a high chance for bleeding. So you might have to treat with systemic therapy first, then do surgery. If the patient is highly symptomatic, if the patient has diffuse mets, for example, diffuse lung mets, there also you might omit. So diffuse visceral mets, highly symptomatic, high beta HCG, all these you might omit inguinal orchidectomy upfront. So the patient needs to be fit, then you do a inguinal orchidectomy. Okay. Now here I also like to talk about a few more points. What is burnt out testis?
Burnt out testis is post treatment, sir. Any or like
Yeah, I'll
unspecified.
just mention
Yeah.
that. So it's not post treatment. What happens is if you have extensive disease, right? Extensive metastasis, there might sometimes be spontaneous regression of the primary testicular malignancy, right? Seen in that setting. Usually it is seen in aggressive tumors like choriocarcinoma. Okay. So in case of all retroperitoneal and mediastinal masses, you should always do an ultrasound testis. This is what they'll ask you when it comes to burnt out testis. If you get any retroperitoneal mediastinal mass that has come out to be GCT, always do an ultrasound testis to rule out a burnt out testis, because it usually presents as a scar or inflammatory findings or microlithiasis. If any of these features are there, you need to consider doing a high inguinal orchidectomy, because 50% of the cases with these ultrasound findings will have presence of will harbor malignancies, right? So burnt out testis, especially in case of choriocarcinoma with extensive mets, if you get a primary, seemingly just a retroperitoneal or mediastinal mass with no testicular malignancy, do an ultrasound testis, look for a scar, inflammation, or microlithiasis. If it is seen, do a high inguinal orchidectomy, and 50% of the cases will have a malignancy. So all these questions will be asked. Okay. Now, one more thing is that one more thing you need to know here is, okay, so we've covered burnt out testis. It's also called Asopari syndrome. Okay. So that is another thing to note here. Now, there's something called testis sparing surgery. Okay. Now, there are many indications, but they'll ask you for the main indication or a partial, for example, a partial orchidectomy. You do that in synchronous bilateral germ cell tumors. Okay. So that is where you might employ testis sparing surgery, where you do a partial orchidectomy. So just remember that in your mind. Now they can, just to, for completion's sake, they might ask you regarding the histopathology for common germ cell tumors. So seminoma is most commonly asked. There you get a fried egg appearance. So you get a large polygon, you get large polygonal cells with clear cytoplasm arranged in sheets, separated by fibrous septa, interspersed with lymphocytes. All these points are important. And 10 to 15% of seminomas have syncytial trophoblasts, which secrete beta-HCG, like we mentioned before. Just seminoma is important. The other ones you need not really know, but seminoma they commonly ask you. They have asked me in national level, like for example, COPE. They've asked. I presented testicular tumors for COPE a couple of years back. They asked this exact question: what is the histopathology of seminoma? Because that's the most commonly seen one, right? Now, IHC is also very important. What is the pan germ cell marker?
So SAL4.
Yeah, so you're right. SAL4 is the pan germ cell marker. Now I'll quickly go through all the histologies and tell you the markers that are commonly seen. Okay. So seminoma, you get SAL4, you get OCT3 and 4, you get PLAP, you get CKIT. Embryonal, you get SAL4, OCT3 and 4, SOX2, CD30, cytokeratin, and EMA. Yolk sac tumors, you get SAL4, cytokeratin, EMA, AFP, and glycipan 3. And choriocarcinoma, you get SAL4, cytokeratin, and EMA. So you should, if you are answering very well, they tend to ask this, what is the IHC? Okay, so be prepared with the answer. Now, SAL4 negative, it is not all testicular GCTs have SAL4 positivity. So in spermatocytic seminoma, in prepubertal yolk sac tumors, you might not get SAL4 positivity. So that is also an exception there that you need to be aware of. Okay. Now, moving on. So you have done your transcortical ultrasound, you have done your markers, you have done your CT, thorax, abdomen, pelvis, right? If needed, you do your MRI. And now you look at the post-op histopathology and you repeat the markers. So when do you repeat the markers?
Sir, at the time, like post-operatively, we will repeat the markers immediately, like whenever they are following up with us at 3 months, 6 months, every 3
So
months.
once you've done your high orchidectomy, you need to risk stratify the patient. So you use your post-op markers. The serum marker should be done minimal of 2 weeks or more. Okay. So if you're repeating it and you repeat it for the purpose of risk stratifying, you do it after 2 weeks. So you need to give at least 2 weeks for the half-life to pass, right? At least 2 to 4 half-life. So minimum of 2 weeks or more. So that is very important, right? Repeating the mark. Now, once you have got your markers, right, now you can stage the disease. So in GCTs in the exam, they will definitely ask you the TNM staging. You should be prepared with the answer. So T1 is limited to the testis and epididymis with no LVI and not involving the tunica vaginalis, right? Uh, so T2 is involving the testis and epididymis with LVSI or if tumor involves the tunica vaginalis. T3 is involvement of the spermatic cord. T4 is involvement of the scrotum. N1 is nodes largest is less than 2 centimeters, uh, less than or equal to 2 centimeters, and N2 is greater than 2 centimeters, but less than or
Less
equal
than
to
five.
5 centimeters.
Five.
And
Yes.
N3 is greater than 5 centimeters, right? So that is the TNM staging. M1A is non-regional nodes or non-regional nodes or pulmonary mets, and M1B is distant mets that are non-pulmonary. Okay, non-pulmonary visceral mets. So what about the markers? How do you classify S1, S2, and S3? Can you tell me?
So yes, sir. It's like we have three components. That is beta HCG, AFP, and LDH. So beta HCG less than 5,000 is S1, and 5 to 50 is S2, and greater than 50 is S3. AFP is not 5,000 but 1,000, 1,000 to 10,000, and greater than 10,000 S1, S2, S3, and LDH less than upper normal limit of 1.5 times. The upper normal limit is S1. From 1.5 to 10 times of the upper normal LDH is S2, and greater than 10 times of the upper normal limit is S3.
Yeah.
So all
So you
three,
have, yeah.
if we
So you
have
have said,
any one, then
yeah, please
we'll
continue.
put. If we have any one of these which are reaching S1, S2, S3, we can put them in that stage.
Okay, yeah, so you're absolutely right. So that is how you classify the based on the serum markers, right? So once you have done your TNM staging and your S stage, then you go to risk classification. So this is based on the IGCCCG, right? So seminoma is classified into good risk and intermediate risk, whereas non-seminoma is classified into good, intermediate, and poor risk. So seminoma does not have a poor risk. Okay. Now, non-seminal is classified based on the marker range, whether there is presence of non-pulmonary visceral mets, right? And the location of the primary. So if it is gonadal, retroperitoneal versus mediastinal. So good risk is if it is in S1 range, if there's no presence of non-pulmonary visceral mets, and if it is a gonadal or retroperitoneal primary. Intermediate is S2 range markers with no non-pulmonary visceral mets with gonadal or retroperitoneal primary. Now, poor risk is if there's a mediastinal primary site or if there's presence of non-pulmonary visceral mets or if markers are in S3 range. So that is it for non-seminoma. Now, for seminoma, there's only good and intermediate risk. The presence is, it is divided only based on the presence of non-pulmonary visceral mets. So regardless of the HCG or LDH level, regardless of the location of the primary, it doesn't matter. Only the presence of non-pulmonary visceral mets will play a role in classification. So good risk is no non-pulmonary visceral mets. Intermediate risk is presence of non-pulmonary visceral mets. So, like I said, markers and primary site do not matter for seminoma. So the interesting thing is that for mediastinal non-seminoma, it comes under poor risk, and for mediastinal seminoma, it comes under good risk. Okay, because the primary site of the germ cell tumor does not matter when it comes to seminoma. So I hope you got that. Understand the definition of good intermediate risk for seminoma and good intermediate and poor risk for non-seminoma. So that is also very important. Now, let's move on. Right. So this IGCCCG scoring of, risk stratification is applicable from stage 2 onwards. Okay. It is not meant for stage 1 patients. Okay. So it is applicable from stage 2 onwards. So that is also another thing to remember. So now coming to the workup for treatment, you will do a CBC bio, you'll do a pulmonary function test. Most importantly, you'll do a DLCO. Okay. Especially for bleomycin clearance, you need to do a DLCO. You do your creat clearance, you do your audiology and cardiac clearance with the echo for your cisplatin. Then you do fertility counseling and baseline serum testosterone and LH. Okay, so all these components I mentioned are very important. Now, what is the chance for infertility at baseline in a germ cell tumor?
So infertility is high, sir. It's like, but exact percentage,
Yeah, so it is around 50 to 60%. It is very high. Okay, 50
yes.
to 60% of patients are infertile at baseline, and you should counsel the patient that fertility increases post treatment. Okay, so once the tumor is cleared, once the disease is controlled, fertility actually increases. Okay, so now so we have done our workup, right? I'll summarize again: transcortal ultrasound. You've done your serum markers at baseline. You've done your CT thorax, abdomen, pelvis, and MRI brain if needed. You've done your high inguinal orchidectomy. You look at the post-op histopathology, and you also do repeat markers after at least 2 weeks, right? You do your workup for treatment with CBC bio, pulmonary function, workup for cisplatin, and fertility counseling with baseline serum testosterone and LH. Okay, so that is the basic workup. You should say this like a song, like you should sing this like a song. Now, let us look at the management very quickly. So when you come to management, you look at stage 1 seminoma first. So stage 1 seminoma, what are the risk factors? So the risk factors are tumor size and stromal invasion of rete testis. Okay, so those are the validated risk factors for seminoma: tumor size and stromal invasion of rete testis. So now, what are the 3 treatments for a seminoma? For
So,
stage 1 seminoma, just
so,
mention the names.
so we can just give carboplatin, AUC7,
Okay.
if it is there is no in stage 1 or active surveillance or PEP, 3 options.
Yeah.
Like,
So I'll slightly modify that. So the 3 options are active surveillance, right? Radiation to the parietic nodes, prophylactic radiation to the parietic nodes, as well as this thing, what do you call it? Uh, Active surveillance, radiation, and single agent carboplatin EUC7. Okay, there's no role for BEP in stage 1 seminoma. So be very clear on that. Let us go one by one. Active surveillance, you need to know the chance for developing um, right. So you need to know the chance for developing a recurrence post high inguinal orchidectomy in a stage 1 seminoma. So if no risk factors are present, it is 6%. If one risk factor is present, it is 12%. If 2 or more risk factors are present, it is 30%. Okay. So overall, it is 20%. So active surveillance, basically, what you do is that there's overall a 20% chance of recurrence only. So the rationale is that you can decrease the toxicity of radiation or chemotherapy because only 20% of the cases overall they tend to recur. Okay. And the interesting thing to note here is that most of the recurrences occur within 3 years. Okay. So they occur within the first 3 years. So you do intensive active surveillance for the first 3 years, and then following that, you decrease the intensity. Now, another thing to note here is that the most common site of relapse is in the retroperitoneal nodes. And so around 75 to 90% of the cases relapse in the retroperitoneal nodes if you do active surveillance, and only 5 to 10 relapse elsewhere, majority in the lung. And 99% of the relapses are good risk category. So they can be treated and cured. So that is the rationale behind active surveillance. Decrease the toxicity of treatment, even if it relapses, only 20% chance of relapse. Even if it relapses, they're in good risk category, 99%, and they can be treated and cured. The cons include, so the risk factors for recurrence post high inguinal orchidectomy are: if no risk factors, 6%; if one risk factor, 12%; if 2 risk factors, 30%. Okay. So I hope everyone got that. So the cons of active surveillance, they'll ask you. So the cost, the logistical constraints, patient anxiety, and of course, in our setting, most important is patient compliance. Okay. So, so that is active surveillance. Now coming to treatments, right? You have adjuvant chemotherapy. So you use injection carboplatin AUC7 single dose. Okay. Now there's also data. This is if the examiner really pushes you, you can say there's also data for 2 doses of carboplatin if multiple risk factors are present. So we know that if 2 risk factors are present, there's a 30% chance for relapse, right? So in that case, you can consider giving 2 cycles of carboplatin AUC7 based on the Swino-TICA trial. Okay, so generally it is a single cycle of AUC7. You can also give 2 cycles if multiple risk factors are present based on the Swino-TICA trial. They'll ask you, how can you say this? Then you mention the trial's name. Okay, now let us look at the comparison of radiation versus carboplatin. What is the advantage of giving carboplatin over radiation? Mainly the effects on fertility are minimal, unlike radiation, and there's no increase in secondary malignancy risk like adjuvant radiation. Okay, so fertility risk as well as secondary malignancies. Also, you decrease the rates of contralateral GCT by giving systemic therapy. Okay, and once again, with carboplatin recurrences are mostly in the retroperitoneum and they are good risk and they can be managed. Okay. So now coming to adjuvant RT. Adjuvant RT, so basically, currently for stage 1 seminoma, you give adjuvant RT at a dose of 20 gray in 10 fractions, right? And you irradiate only the para-aortic node, the para-aortic strip. So earlier we used to irradiate the entire dogleg field for stage 1, but now there's an MRC trial which show that para-aortic is equal to irradiating the para-aortic plus pelvic nodes. That is a dogleg field. So only para-aortic strip radiation is required, and the dose is 20 grain, 10 fractions. Okay, so you need to know the field borders. So this is some RT thing that they can ask you. Field borders are upper border is T11 to T12 and lower border is L5 to S1 junction, and the lateral borders are the transverse processes of the vertebrae, right? So I hope you got the borders. So for left-sided tumors, you should extend the lateral border to include the left renal hilum. What is the reason for that, they might ask you? It's because the left testicular vein, it drains into the left renal vein rather than directly into the IVC. So when you're writing the para-aortic area, you should also include the left renal hilum. That is an extra question they can ask you. So of course, what are the cons? Like we discussed earlier with RT, it's secondary malignancies, infertility, cardiovascular effects, etc. Okay, so that's why RT is sort of fallen out of favor. Usually we do active surveillance. In our setting, we tend to give carboplatin AUC7. RT is fallen out of favor because of infertility effects, secondary malignancies, and cardiovascular effects, right? And one more question they can ask you is, what are the contraindications of radiation? So the contraindications are presence of horseshoe kidney and inflammatory bowel disease. Okay. Now, let's go on to the management of stage 1 non-seminoma. So stage 1 non-seminoma, the validated risk factors are mainly LVI, lymphovascular invasion. So that is the main validated risk factor. Others that have been seen in other trials include presence of embryonal component, presence of T3, T4 disease. Okay, so disease that is involving the spermatocorn scrotum, or presence of embryonal component, but most major one that you should mention first is LVI. Okay, so now when it comes to management of stage 1 non-seminoma, there you should, the options include, once again, active surveillance, then retroperitoneal lymph node dissection, or single cycle of BEP. So these are the three options. How do we go about deciding between these three options, right? So active surveillance here, what is the recurrence rate post high inguinal orchidectomy? We should know that, just like seminoma. So if no risk factor is there, there's 12% chance for recurrence. If there's one risk factor, there's 50% chance for recurrence, right? So infinitely higher if there's one risk factor. So that is something that you need to keep in mind. Overall, there's 30% chance for recurrence, right? So definitely it is higher than seminoma. So now coming to active surveillance, the things that you need to know here is that active surveillance is usually done for stage 1 non-seminoma without risk factors, because we know that once you have risk factors, the recurrence rate goes up to 50%. So without risk factors, the recurrence rate is only 12%. So active surveillance might not be that useful for non-seminoma with risk factors. So for stage 1 without risk factors, you can do active surveillance, RPLND, or BP single cycle. All three are valid options. You would prefer doing active surveillance because the recurrence rate is only 12% without risk factors. And active surveillance, like, majority of the relapses, once again, are good risk. Here, 2/3 relapse in the retroperitoneal nodes and 1/3 relapse mostly in the lungs if you do active surveillance. So slightly higher percentage in the lungs, probably because it is a non-seminoma, but majority of them are good risk and can be salvaged. Okay, so that is for stage 1 without risk factors. You prefer active surveillance. Also, you can give BP or RPLND alone. Those are also options, but we go for active surveillance. If risk factors are present, then you should consider active surveillance might not be a good option. You might switch towards, lean towards BP single cycle or retroperitoneal lymph node dissection. Okay, so that is what you lean toward if there is presence of risk factors in a non-seminoma stage 1. Now, if you have embryonal component, if one of those risk factors happens to be embryonal component, there you might think of one cycle of BEP rather than RPLND. So RPLND and BEP are preferred over active surveillance alone if risk factors are present. And if embryonal component is one of those risk factors, you might prefer BP over RPLND, because embryonal compound can metastasize directly to the lungs. So RPLND might not be of much use there. So I hope you got the treatment of stage 1 non-seminomas. Without risk factors, active surveillance is preferred. Stage 1 with risk factors, RPLND or single agent cycle of BEP is preferred. If embryonal compound is there, single cycle of BEP is preferred. So that is the basic treatment overview there. Now, just to complete stage 1, there's something called stage 1S. Stage 1S is, so they'll ask you this: if there is positive serum markers in a stage 1 disease post high inguinal orchidectomy. So you do high inguinal orchidectomy, but there is no disease on imaging elsewhere, but the markers are still raised. That is considered to be stage 1S. Then that you give 3 cycles of BEP. Okay, so that is how you manage that. Now, let us look at retroperitoneal lymph node dissection. What are the types? So there's a classic bilateral retroperitoneal lymph node dissection where the chance for retrograde ejaculation. So that is the main toxicity of RPLND, retrograde ejaculation leading to infertility. So classical bilateral RPLND has a chance of retrograde ejaculation of greater than 95%. Then we evolved to template-based RPLND, where based on the nodal involvement, we restricted our retroperitoneal lymph node dissection. Then we have currently evolved to nerve-sparing bilateral RPLND, and that is what you should say when you mention RPLND. It should always be nerve-sparing. There, the retrograde ejaculation chances are less than 5%. Okay, so that is also something that you need to mention. Now, sometimes another scenario that will rise is sometimes you might, dissect a stage 1 disease. You might treat it with RPLND. You have given RPLND, and within the RPLND specimen, you might get positive retroperitoneal lymph nodes. So if for stage 1 non-seminoma, you have done RPLND, and within that there are positive nodes, then you might have to consolidate. So if you have a PN1 disease post RPLND on a seemingly stage 1 non-seminoma, if you've done RPLND as treatment, and if you get positive nodes in the pathological specimen, if you have PN1, you give 2 cycles of BEP. If you have PN2, you give 2 cycles of BEP. If you get PN3, which is unlikely, you should give 3 cycles of BEP. So RPLND, if you're done for stage 1, if you get positive nodes, this is how you treat it. Okay. Now, okay, good. So one more thing. So now we have discussed stage 1 management of seminoma and non-seminoma. Let us look at the role of radiation in. So beyond stage 1, we know that non-seminoma, there's no role of radiation. In seminoma, it is there as an option stage 1. In stage 2, radiation is also used. It is used in stage 2A patients and stage 2B up to 3 centimeters. So moment in stage 2B, once you go above 3 centimeters, if you treat with RT alone, the recurrence rate chance goes greater than 30%. So stage 2A and 2B seminoma up to 3 centimeter size, you treat with, you can also treat with radiation. Okay. So the radiation, unlike for stage 1, in stage 2 and stage 2B up to 3 centimeters, you give the classic, the modified dog-leg field or hockey stick field. Okay, so this is something they will definitely ask you in the exam, even though it is art related, but it is important for us to know this. So upper borders T11 to T12, lateral borders are the transverse process of the vertebrae, and at the midpoint of the L4 vertebrae, you deviate to the ipsilateral side, right, of testicular involvement, and it extends to the superior aspect of the acetabulum. So T11, T12 upper border, lateral borders are the transverse process of vertebrae. Once you get to the midpoint of the L4 vertebrae, then you go to the side where the testis is involved. The field deviates to the side and ends at the superior aspect of the acetabulum. So that is the modified dogleg field that is currently used in stage 2A and stage 2B seminomas up to 3 centimeters, although that is not preferred. Right? That is one of the options. You should know that, but that is not preferred. Okay. So now moving on, right? Now we need to, so I've given you all the scenarios of management stage 1, all the points that you should mention. Everything is very important. Okay. You need to remember everything. If you remember all these points, you'll be able to answer almost all questions, I feel. Now, coming to the treatment protocol. Here we need to know, okay. Yeah. So what is the how do you treat good risk? So for seminoma or non-seminoma, we know that seminoma is only good risk and intermediate risk. Non-seminoma is all 3. How do you treat, regardless of what histology it is, how do you treat good risk disease? Can you tell me?
So BP, like we will track the
How many
serum
cycles
markers.
and what regimen?
3 cycles of BP, sir.
Or
Uh, 3 or 4. Uh, or EP 4 cycles.
yeah,
If we are eliminating bleomycin.
yeah. Intermediate and poor
Three
risk, how will you treat?
BP we will give 4 cycles.
Yeah. So you said it right. Good risk, you can give 3 cycles of BP, or you can replace with 4 cycles of EP if bleomycin is contraindicated. Intermediate and poor risk, you have to
Can't.
give 4 cycles of BP. Okay. So
Uh,
that is the basic treatment protocol based on risk, right? For stage 2 and above. Now, at this point, let's take a 30-second breather. Okay, just drink some water. At least I need a sip of water. Okay, so this patient comes to you, for example, with intermediate grade. It's an intermediate grade, non-seminoma, right? So how would you administer the BEP protocol? That is a question. Okay, so if you can quickly tell me how you would give it.
Day BP day 1 and day 8 of bleomycin, and on day 1, 2, and 3 we will admit them and we will give EP, and we will do platinum of 40 cisplatin 40 milligrams, or split those, and in etoposide also we will give
Yeah, so I,
2.
I I will tell you how to. If the examiner asks you how do you administer this BP regimen, this is how you should answer it. Okay, start off with the antiemetic prophylactic medications. Okay, so you give antiemetic. This is a highly emetogenic
I
regimen
Yes,
because of
sir.
the presence of cisplatin. Okay, so you
So
give
for
ondansetron 8 mg, you give dexa 8 mg, you give fosaprepitant or aprepitant 150 fosaprepitant, you give 150 mg in 100 ml over 30 minutes, or if fosaprepitant you give 125 mg day 1,
125,
80 mg day 2 and
80.
day 3. Okay, so that is the prophylactic antiemetics. Following that, so you've given your prophylactic antiemetics. You can also start off with olanzapine on day 1, right? Since it's highly emetogenic. So once you do that, you start off with bleomycin first, right? Bleomycin is given at fixed dose of 30 international units on day 1, day 8, and day 15. Another question they will ask you is, what is the pre-medication for bleomycin? You can give 100. So along with these antiemetic pre-medications, you can also give 100 mg hydrocortisone injection before bleomycin to prevent fever, chills, and hypersensitivity due to bleomycin. That is also common. So antiemetic protocols that I mentioned, plus injection hydrocortisone just before bleomycin injection. So bleomycin, you give it as 30 international units in 100 ml NS over 30 minutes. Okay, so you have given that. Then you give etoposide, right? Etoposide is given at a dose of 100 milligram per meter square, day 1 to day 5, right? So day 1 to day 5. So bleomycin you have given on day 1, right? Then you should give it on day 8 and day 15, just like that. Whereas etoposide is given 100 milligram per meter square, day 1 to day 5, and you give that in 300 ml, depending on your institute, 300 to 500 ml of NS, and you should give that in greater than 30 minutes. Why so? Why greater than 30 minutes? Because it can cause severe hypotension. Okay. So greater than 30 minutes is very important. So you have given your bleomycin, you have given your etoposide, 100 milligram per meter square, day 1 to day 5. Then next is cisplatin, 20 milligram per meter square, day 1 to day 5. Now, depending on your institute, follow your institute protocol. You might give 2 liters of hydration, or you might give just 1 liter of hydration. So I will describe if your institute, like my institute, gives 2 liters of hydration. So what we tend to do is we'll give 1000 ml of NS over 2 to 3 hours. Following that, we'll give mannitol 200 ml. 200 ml 20% or 400 ml 10% over 30 minutes. Then we'll give cisplatin. We'll give that in over. So since the lower dose, we can give it in 30 minutes to 1 hour. Okay. And following cisplatin, so before giving cisplatin, you'll ensure that the patient has 100 ml per hour of urination. Then you give cisplatin. So 1 liter of hydration, mannitol, cisplatin over 1 hour. And following cisplatin, you'll give 1 liter of NS. And in that 1 liter of NS, you can add magnesium sulfate 2 ampules and KCl 1 to 2 ampules. Okay. So that is how we tend to give it. Although you can also get away with giving 500 ml of NS before cisplatin, followed by 500 ml of NS after cisplatin. Why? Because this is a lower dose. We're only giving 20 milligram per meter square per day. So it depends on your institute, whether you give 2 liters with mannitol or with KCl and magnesium sulfate, or whether you just give 1 liter of fluids before and 500 ml before and after cisplatin. Because it's a lower dose. For higher dose of cisplatin in other malignancies, like we discussed in head and neck, you need to give those 2 liters, it is a given. So here, depending on your institute, for this lower dose of cisplatin, you might decide to go 2 liters or 1 liter. So that depends on your institute. So stick to your institute protocol, right? So once you've given cisplatin, that's 20 milligram per meter square, day 1 to day 5, you talk about your post-chemotherapy antiemetic cover. So if you just go by the textbook, you give Dexa 4-mg BD, right? And along with Pan 40, along with olanzapine, day 1 to day 3, post-chemotherapy. But sometimes in our institute, you might go with Dexa and MSit and Pan rather than, so it depends on your institute. But textbook is Dexa, olanzapine plus Pan 40, but stick to your institution protocol. In most places, you go for Dexa, MSit and Pan, right? Some people might not even give adjunct or olanzapine. So it depends. So I hope you got how to say the protocol, right? Antiemetic cover, hydrocortisone before bleomycin, etoposide greater than 30 minutes, as will cause severe hypotension. Cisplatin, the hydration protocol, you should know post chemotherapy treatment, right? Now, at this point, the examiner will definitely ask you about each of the chemotherapy regimens. Okay, each of the chemotherapy agents. So bleomycin, right? So bleomycin, you should know the mechanism of action. So the mechanism of action is basically, yeah. So
Free
it is
radical.
yeah. So free radical, you're right. So basically, it's transported inside the cell via copper. Then it binds to iron 2 plus, and it gets oxidized to 3 plus, which then enters the nucleus, and then it leads to DNA breaks, right? Through its through activated oxygen free radical species, that is Fe3 plus, which is attached to bleomycin. So that is how the mechanism of action is. Pre-medication, like I mentioned, not a lot of people know this. It is 100 mg hydrocortisone to prevent, your fever, chills, and hypersensitivity skin reactions that are seen when you give bleomycin sometimes. Side effects you should know, of course, the main side effect is pulmonary toxicity, right?
Skin stripe.
Yeah, skin, sorry, exactly. So you get hyperkeratosis of skin and nails. So know all the toxicities, okay? Hyperkeratosis of skin and nails, erythematosis, flagellated hyperpigmentation, rash, striae, and sclerodermoid lesions, right? So that is usually seen with a cumulative bleomycin dose of 100 to 200. Okay. The most characteristic one is erythematous flagellated hyperpigmentation. Then you get pulmonary toxicity, which is seen with many risk factors. We'll talk about those. And with a dose of greater than 400 or more, usually you get pneumonitis and you can progress to ILD. Hypersensitivity reactions, like I mentioned before, and myelosuppression is very less and nausea and vomiting is very less, which is why when you give bleomycin on day 8 and day 15, you need not give much antiemetic cover. Okay. So keeping all that in mind, so those are the side effects there. Now you need to know what are the relative and so the relative and absolute contraindications for giving bleomycin. Okay, so the absolute contraindication if the DLCO is less than 30%. DLCO less than 30% is absolute contraindication. Relative contraindications include DLCO is less than greater than 30%, but less than 60%. So ideally, DLC should be greater than 60. If less than 30, it is an absolute contraindication indication for bleomycin. If 30 to 60, it is a relative contraindication. Then other relative features to omit bleomycin are older age greater than 40 years, a cumulative exposure. Previously, if the patient treated, for example, Hodgkin's disease, they might already have a cumulative exposure of greater than 360 to 400 units. If the patient has impaired kidney function, right, because bleomycin is excreted to the kidneys, so the patient has AKI or CKD, that you might have to omit. If the patient is previously received thoracic RT, right? That is another relative contraindication. If you're planning for thoracic surgery, so example, a mediastinal non-symptomatous germ cell tumor, after giving chemotherapy, you have to resect the residual mass. So there you might have to omit bleomycin. You might have to give another regimen like VIP. So planned thoracic surgery, so example, mediastinal non-symptomatous germ cell tumor, you might have to omit bleomycin. So that's a relative contraindication. If you're expecting a high FiO2, so when you're giving oxygen while on bleomycin therapy, the FiO2 should not go greater than 30%. So if the patient, because of its comorbidities, requires an FiO2 of greater than 30%, that can accelerate bleomycin lung toxicity. If the patient has a history of smoking, the patient has a history of previous lung pathology like COPD, and if you're expecting GCSF use in that patient, right? So we know that GCSF also is a risk factor for developing bleomycin-induced lung damage. So it should be avoided ideally. But if you're expecting GCSF use upfront, then you might have to omit it. Now, another thing to note is that in Hodgkin's disease, what is the risk the person? So all these points, the absolute and relative, are very important. You should say it verbatim in your practical exams. Now, what are so GCSF and bleomycin in Hodgkin's disease? The risk for pneumonitis when combining ABVD GCSF is around 10 to 15%. In germ cell tumors, when you combine with a BEP with GCSF, it is only around 5, up to 5%. So it is much lesser when combining in setting of Hodgkin's disease. We do not know the reason for that, but so Hodgkin's disease, bleomycin, we avoid at all costs. BP regimen, we can consider we can consider GCSF if really required, right? So it's not completely contraindicated like Hodgkin's, but it can be considered. Why can it be considered? Because the risk of pneumonitis is far lesser than that seen in Hodgkin's disease. So you need to know that as well. Another question they'll ask you is, what is the mechanism of pneumonitis? The reason is that there's a relative deficiency of deactivating enzyme bleomycin hydrolase in the lungs, right? So that can lead to increase, formation of free radicals and increase lung toxicity because of the deficiency of bleomycin hydrolase. So that's also.
Sir, in Hodgkin's, it's only 10 units, no, sir? Bleomycin.
Yeah. So in Hodgkin's disease, you give it at 10 units per meter square. Okay. So there it's not a fixed dose, it's meter square, an ABUD regimen. And there the pneumonitis is very high for some reason. It is around 10 to 15%. So that's why we avoid GCSF at all costs. BP regimen, it is lesser, 5%. We do not know, probably it's something related to the disease pathology. But BP, although it is relative contraindication, but if it's really required, you can consider using. That's the difference. Okay, can you practically see? Okay, now moving on. Cisplatin. So here they will ask you. So yeah, if bleomycin is contraindicated, if it is good risk, you can give EP instead of BEP. And if bleomycin is contraindicated in intermediate or poor risk, you can give VIP. Okay. Okay. So etoposide, ifosfamide, and cisplatin. So that if intermediate and high poor risk, you can give VIP. If good risk, you can omit bleomycin and give EP into 4 cycles. So now cisplatin, when was it introduced in the management of germ cell tumors and by which scientist?
So it was actually the discovery. The discovery happened in germ cell tumor only of cisplatin. I think it was one of the first chemotherapy drugs ever that worked. It was the first one, and
it is by a scientist called Einhorn. Okay, and it was done in 1974 and transformed the treatment of germ cell tumors. Okay, it improved the outcomes significantly. Now, another question is, why does cisplatin work so well in germ cell tumors? That is another question they can ask you. Because cisplatin enters the tumor cell to the OCT transporters. Okay, so OCT transporters. So there's high expression of this OCT transporter on these germ cell tumor cells. Another reason that they've given in CHU as well as they've given it in CHU is that there's a high expression of HMG box enzymes, HMGB enzymes. Okay. Sorry, it's not an enzyme, HMGB gene expression. Okay. So because it is expressed, this HMG box gene is expressed in high levels, it leads to increased sensitivity to cisplatin. How does it do that? This HMG binds to the DNA damage that is caused. So the broken DNA strands that cisplatin causes, right? So cisplatin causes intrastrand linkages, adducts, and then breaks the DNA. So this binds to the broken DNA strands and prevents this HMGB, which is highly expressed in GCTs. It binds to the broken DNA strands broken by cisplatin, and it prevents the repair. So that is why this OCK expression and HMG are the reasons why the high expression of both these are the reasons why cisplatin is highly sensitive in GCTs. Okay. So now toxicity of cisplatin we have discussed in the head and neck class. I won't get too much into that. You've got nephrotoxicity, autotoxicity, myelosuppression, neuropathy, all these toxicities, right? So you need to be aware of that. Now, another thing here is etoposide I mentioned. Etoposide causes myelosuppression. It causes, nausea, vomiting, diarrhea. It can cause secondary malignancies. So secondary malignancies mostly seen are
And
AML. Yeah, AML without MDS. So unlike alkylating agents, which have a latency period of 5 to 7 years and develop MDS first, then AML, etoposide goes directly to AML and the latency period is lesser. It is 2 to 3 years and it's associated with the MLL or KMT-CA gene. Okay. KMT is that gene. So MLL or KMT is that gene. And the latency is only 2 years and it is direct progression to AML rather than with preceding MDS. So that is something that you need to know. Okay. So moving on, we need to know what are, this is another question, that favorite question in testicular lymphomas, what are the investigations that you will consider doing before each cycle? So before each cycle, you will do a history and physical examination. Along with that, you would look at the respiratory rate of the patient, the SpO2 of the patient, as well as single breath count, how much the patient can count for with a single inhaled breath. Then ideally, you should do a pulmonary function test prior to each cycle. And so that is ideally, we do not tend to do that in most of our settings, but ideally you should do a PFT before each cycle. Of course, you'll do CBC, LFT, RFT, electrolytes, right? Electrolytes, especially, RFT, cisplatin can cause non-oliguric AKI, and it can also cause hypokalemia, hypomagnesemia, hypophosphatemia, hypocalcemia, etc. So all that we need to watch out for, especially if you have renal function, renal dysfunction. It is, you need to be careful because it can enhance bleomycin toxicity because bleomycin is excreted through the kidneys, right? So CBC, LFT, RFT, electrolytes, and ideally you should do your serum markers before every cycle. Although some institutes don't do that, but ideally you can mention this in an exam. It is an acceptable answer. Actually, it is a standard answer. Serum markers before every cycle, and you look for a log decrease. Okay, ideally there should be a log decrease, but suppose you've given one cycle of BEP. Okay, the baseline post-op serum markers, which is the baseline, was, AFP was 5,000. Now, you have given one cycle of BEP and you've done your serum markers, the AFP has come down to 4,900. It's not a log decrease that you would ideally expect. So should you switch treatment?
So, in case of serum markers, which like if the FDG ability based on just based on one cycle,
Just the markers. So my point I'm trying to tell you is that we look at markers before each cycle. Ideally, there should ideally be a log decrease, but if there is no increase, suppose the decrease is only, for example, 5,000 to 4,900, even then you should continue with chemotherapy. You should not switch the agent. You should not, you should continue with the same regimen. Any decrease, you should continue with the same regimen. The only time where you will stop that particular regimen is if there's some sort of increase. But even if the decrease is only slight, you still continue. This is something that they'll ask you in the exam. During chemotherapy, when you monitor with markers, if the decrease is not ideal, should you continue? You should still continue. As long as there is a decrease, even if it is 1 or 2, you should still continue. That is the standard. Okay. So, like I said, history and physical examination, respiratory rate, SpO2, single breath count, pulmonary function tests, CBC, RFT, electrolytes, serum markers before every cycle, all of that. Okay. So now, what are some miscellaneous questions that they can ask you? In good risk, we give so if you have answered all of this, you are like, you're in that distinction level, you're, now in proximity to your gold medal. So to get there, they'll ask you some more questions. Good risk. There is a phase 3 trial looking at EP versus BEP. Is there any advantage of giving BEP or EP? That's the question they'll give. EP into 4 versus BEP into 3. So whenever possible, you should give BEP into 3, because this phase 3 trial showed that giving 3 cycles of BEP had a EFS advantage over giving 4 cycles of EP. So although 4 cycles of EP is also acceptable for good risk, you should always give 3 cycles of BP wherever possible because of the EFS benefit, although the OS was the same. Okay, next is VIP versus BEP. Why did BEP become standard of care and is preferred over VIP? Although VIP is used for bleomycin is contraindicated for intermediate and poor risk. So there's a phase 3 trial looking at VIP versus BEP for intermediate versus and poor risk, and there was no difference in DFS or OS. But there was an increase in hematological toxicity and kidney toxicity with VIP, which is why we prefer BEP. Now, another question they'll ask you is there any role for alternating chemo regimen? Like there were trials that looked at BEP alternating with VIP. So there is no benefit of alternating BEP versus with VIP. Okay, the trial data has shown no benefit. Another thing another question that they can ask you here is the sub-classification of good risk seminoma. Okay, so that is also very important, the sub-classification of good risk seminoma. So currently there's been an update where they have further classified good risk in seminoma based on the LDH level. So greater than 2.5 into upper limit of LDH, it is considered to be within good risk, it's considered to be slightly poorer prognosis, and less than 2.5 into upper limit of LDH, it is slightly better prognosis. So good risk has been further subclassified. So that is an additional point. Now, another thing is brain metastasis. If you have upfront brain metastasis, you consider surgery. Yeah, so good risk in seminoma was further subclassified recently based on the LDH level, and 2.5 into upper limit was the cutoff. Okay, intermediate risk was not subclassified, good risk only. So now, brain metastasis, how do you deal with that? So if you get upfront brain metastasis, you do surgery if there is herniation, impending herniation or bleeding. Okay, so those are the indications for surgery. Otherwise, you treat with radiation, SRS or WBRT. Okay, with prephase treatment. So prephase treatment is you will give only EP, you will give it for 3 days only. Okay, so for brain mets, if herniation or bleeding, then you have to do surgery. If there is no herniation or bleeding, but there's symptomatic brain mets, there you should start off with what you call SRS or WBRT and combine with prephase chemotherapy. Okay, so that is how you treat. Now, during treatment, if you develop brain mets, what should you do? During treatment, if you develop brain metastasis, you should do a brain MRI and you do a CT thorax, abdomen, and pelvis. If the systemic disease, the extracranial disease is under control and it is only progressing in the brain, and is only brain mets have developed, but the extracranial disease has responded well, then you can treat locally, you can treat the brain disease locally and continue the same regimen. If the extracranial disease is also progressing, then you need to switch the regimen. Okay, so that is very important. That is something they can ask you. Then, of course, there's something called choriocarcinoma syndrome, right? So choriocarcinoma syndrome, it's seen especially, it's seen in choriocarcinomas, which can occur alone or most commonly as in mixed non-seminomatous germ cell tumor, right? So it's associated with HCG of, greater than 1 lakh to 1 million. You have, spread to you have distant mets. So you have diffuse lung mets and non-pulmonary visceral mets. You have brain metastasis. You have high risk for tumor hemorrhage, IC bleed, hemoptysis, etc. You have features of hyperthyroidism because of similar structure of HCG to TSH, right? And high rate of mortality. So in these patients, do not start off with BP or triplet because bleomycin can lead to increased risk of pulmonary hemorrhage. Okay, so always start off with EP into 3 days. So cisplatin, 20 milligram per meter square, day 1 to day 3. Etoposide, 100 milligram, day 1 to day 3. Start off with the prephase, stabilize the patients. And once the patient is stabilized, you can give even 1 or 2 prephase cycles, okay, till the patient is stabilized. Okay. And yeah, like someone mentioned in the chat, you should always try to avoid biopsy. Okay, because biopsy can lead to bleed. And if there's any active bleeding site, you might have to surgically intervene, especially in the brain. Okay. So, and also in this setting, you might have to consider delaying high inguinal orchidectomy if the beta HCG is raised, right? It can be done later after doing your after giving your systemic therapy. So that is how to deal with choriocarcinoma syndrome. So all those points are very important. Now, the next important point is evaluation post-treatment. I'll quickly mention it. So in seminoma, once you've completed your treatment, what you do is at 6 weeks after the last chemotherapy cycle, 6 weeks, okay, you repeat your tumor markers and you do a CT, thorax, abdomen, and pelvis. So if the tumor markers are normal, you do a CT, thorax, abdomen, and pelvis for seminoma at 6 weeks. Now, you look at the size of the residual disease in the CT scan. If the residual disease is less than 3 centimeters, less than or equal to 3 centimeters, you need to continue normal follow-up. But if the residual disease on CT is greater than 3 centimeters, along with normal tumor markers, you should do a PET CT, okay, at 6 weeks, okay. So tumor markers you do at 6 weeks. If they're normal, you do CT, thorax, abdomen, pelvis. Look at the size of residual disease. 3 centimeters is the cutoff. If greater than 3 centimeters, do a PET CT, right? And in PET CT, if it is negative, there's no uptake, you can do surveillance. If it is positive, you should consider resection. If not, a biopsy from the PET of its side. Okay. Now, in this resection or biopsy, if it is positive, you might have to give, if you're able to see a positive uptake in PET CT in a greater than 3 centimeter lesion size, then you have to do a resection ideally. If you've done your resection, then what you can do is, if that resected mass has residual disease, you can give 2 cycles of TIP or 2 cycles of EP. Okay. So you've done your tumor markers at 6 weeks, you've done a CT, the lesion is greater than 3 centimeters, so you do a PET CT, and based on the PET CT, if there is positive uptake, then you try to do an excision of the entire lesion. If within the excised sample there is residual disease, you give 2 cycles of TIP or 2 cycles of EP. Both are accepted. Now, suppose you can only do a biopsy, right? And the biopsy, if it comes out to be negative, it's fine. But if the biopsy is positive, then you have to give second line treatment. So 2 cycles of TIP or EP are not involved. If you cannot do an excision, if you can only do a biopsy, and if there is positive biopsy, then you need to give second line treatment. Okay. So 2 cycles of TIP or EP are not enough, unlike when you do an excision. So when it comes to non-seminoma, here you have to, so second line treatment is given if markers are raised at 6 weeks, or if PET CT avid lesion is there that cannot be fully excised. If PET CT avid lesion is there that can be fully excised that has residual disease, there you give only 2 cycles of TIP and EP. I hope you got that. So this is based on the SEMPET trial. SEMPET trial has given this cutoff, and PET CT in evaluation of post-treatment evaluation of seminoma has 80% sensitivity, 100% specificity, and 96% negative or positive NPV value. Okay, so remember all those values as well. Now, evaluation of non-seminoma, what you do is, at 6 to 8 weeks, you do your tumor markers, make sure they're normal, right? If they're not normal, you give second line. If they're normal, then you do a CT. There's no role for PET CT in post-treatment evaluation of non-seminoma. If you look at the size of the residual mass. If the residual mass is less than or equal to 1 centimeter, you can do surveillance. Okay. If the mass is greater than 1 centimeters, then you need to excise the mass. Most commonly, you get residual mass greater than 1 centimeter in the retroperitoneal region. So there you do a bilateral nerve sparing retroperitoneal lymph node dissection. Okay. So if you get masses, say example, in the lungs that are greater than 1 centimeter, there also you need to excise those masses. So you can do a wedge resection of the lung masses that are greater than 1 centimeter. So any lesion greater than 1 centimeters in normal serum markers at 6 to 8 weeks, you need to excise it. Most commonly seen in retroperitoneal nodes, you do a bilateral retroperitoneal lymph node dissection. Okay. So that is the treatment there. And once you excise the lesion, right, the residual disease greater than 1 centimeter, what is the risk of residual disease within that excised mass? That is also very important. 15% chance for malignancy, 45% chance for fibrosis, and 40% chance for teratoma. So that is the breakdown. They'll definitely ask this question, right? And if there is residual disease and you've completely excised the residual disease with RPLND or excision of other sites, then you need to only give 2 cycles of TIP or 2 cycles of EP. If you're not able to completely excise the disease, then you need to give second line treatment. Okay. Another point to note here is that we do excision of the lesions greater than 1 centimeter in size, right? 15% is malignancy, 40% is fibrosis, 40% is teratoma. Now, if the tumor markers are normal and the residual disease is less than 1 centimeters, we can go for surveillance. But there's a small risk here of something called growing teratoma syndrome. Okay, there's a 5-year risk is very low. It's around 1 to 2% when you don't do excision in a residual mass less than 1 centimeters, which is the standard of care, right? We don't need to do excision there. So chance for growing teratoma syndrome is 1 to 2%. That is the residual disease less than 1 centimeter, although the chances of malignancy are very less. That's why we do surveillance. But teratoma can be there. There's a 1 to 2% chance of growing teratoma syndrome. So the mass increases in size, right? It can be due to a residual teratomatous component. It is important, they'll ask you this in the exam, because it can lead to malignant transformation. It can grow into a neuroendocrine tumor or can grow into rhabdomyosarcomatous element, right? So that is why growing teratoma syndrome is very important. It can be rarely seen when you do surveillance in a lesion that is less than 1 centimeter. Okay, so that is also another thing that you need to, be aware of. Okay, so now coming to second line treatment. So if the serum markers are still raised or there's a residual disease, you're not able to do complete excision, right? Or if, right, so you're not able to complete excision of the residual disease, there you give second line treatment. So the chance for salvage is around 50%, right? With second line treatment, usually we give TIP regimen. TIP regimen is given, consists of paclitaxel, ifosfamide, and cisplatin. Interesting thing to note here is that paclitaxel is given at 250 milligram per meter square, right, over 24 hours. Okay, so that is the regimen is slightly different. Paclitaxel is not given over 3 hours, it's given over 24 hours, 250 milligram per meter square, followed by ifosfamide, 1.5 grams per meter square, day 2 to day 5, and cisplatin, 25 milligram per meter square, day 2 to day 5. It's given every 3 weeks. Okay, so TIP regimen you need to be aware of. Then another question they can ask you is role of transplant. Okay, so role of transplant, it is currently approved in the third line setting. And usually you give high dose carboplatin and etoposide. So 750 milligram per meter square of etoposide for 3 days and 700 milligram per meter square of carboplatin for 3 days. And you can repeat 2 cycles of that as induction, as a conditioning regimen. And there is a trial going on called the Tiger trial, looking at the role of transplant in second line setting. So they're comparing TIP versus TICE. So TIP, your regular TIP regimen in second line setting versus paclitaxel ifosfamide alternating with carboplatin etoposide, right, followed by transplant. So they're looking at whether this TICE regimen with transplant has an advantage over TIP. So that is an ongoing trial. Okay. So with transplant, you should know 2 criteria. The Bayer criteria, BEYER criteria. So that is a classical criteria. So that is, it's classified based on progressive disease. It looks at various adverse risk factors. So progressive disease before transplant, primary mediastinal site, refractory or absolute refractory to cisplatin, HCG greater than 1000. So all those risk factors are looked at, and it is classified into good, intermediate, and poor. And based on that, you decide whether the patient is a candidate for transplant or not. If it is poor, that is more than 2 risk factors, the patient might not be a candidate, might not benefit from transplant in third line setting, right? Then you also have International Prognostic Factor Study, IPFS score. You can just look that up, right? And so, yeah. So before we wind down, third line setting usually give VELP, GEMOX, GEMPACLI, right? And third line setting is generally where transplant is currently approved. And sometimes when you give treatment, so one other point I'd like to bring out here is that unlike your first line setting where you give chemotherapy and make sure that the serum markers are normalized, right? If the serum markers are not normalized, you have to proceed to second line. But in the second and third line setting, once you've given chemotherapy, if there's no residual disease, right? If the serum markers have not normalized, so if given second or third line, the serum markers have not normalized, even then you do not proceed to the next line. You do surgical removal of the residual disease regardless. So in second and third line, it's different. Serum markers, even if they're not normalized, you do surgical resection of the residual disease. That is called desperation surgery. That is done in second and third line. Okay. So next question they can ask you is treatment sequelae. So we are winding up now. So you have cardiovascular effects, including metabolic syndrome due to cisplatin, due to decrease, prolonged, presence of cisplatin in the body. You have neurotoxicity due to cisplatin. You have hypogonadism and infertility due to chemotherapy, RPLND, right? And sometimes patient might require testosterone supplementation due to hypogonadism. You have autotoxicity due to cisplatin, right? You have secondary malignancies can be due to chemotherapy, like etoposide can lead to AML, especially if the dose is greater than 2 gram per meter square. If you're given cumulative dose of greater than 2 gram per meter square, there is a up to 5% chance of developing AML, right? With etoposide. Also, radiation can lead to secondary malignancies. So you need to be aware of all that. Uh, Acute leukemias can raise in mediastinal non-seminomatous germ cell tumors with a yolk sac component, because this yolk sac component is a source of hematopoiesis. It can lead to acute leukemias, especially in mediastinal non-seminomatous germ cell tumors with yolk sac component, right? And of course, you have contralateral testicular tumor in 2 to 3% of the cases. So those are some of the sequelae that we look at. Uh, Now, uh, one more thing that you need to note here is there are two other regimens, pediatric regimens called JEB regimen, right? Capital JEB regimen. So here they have replaced cisplatin with carboplatin because cisplatin has a high chance for autotoxicity, especially in children less than the age of 10 years. So you can use a JEB regimen. There's also a PEB regimen, with B being in small letters, right? So capital PE, small b uh, is so PEB regimen with small b. So there you only give 1 day of bleomycin rather than day 1, 8, and 15, because of the you don't want the young child to undergo the toxicities of bleomycin. So that is 15 units per meter square. So it's not a fixed dose. You give 15 units per meter square day 1 only. So that is the PEB with B in small letters. Okay. Another thing that you need to note here is the treatment of mediastinal germ cell tumors. We are just winding up the last 2 points. Mediastinal germ cell tumors, if it is seminoma, you give it is good risk, so you give 3 cycles of BEP. If it is non-seminoma, you might be anticipating a thoracic surgery. So you give 4 cycles of VIP because the response is not that good in non-seminoma, right? Seminoma is very good risk. So 3 cycles of BP will take care of it. 95% survival rate. Even this Yuvraj Singh had mediastinal seminoma. Non-seminoma, the responses are not that good. And you are anticipating having to excise the residual mass. So there you give 4 cycles of VIP because you're anticipating thoracic surgery in non-seminomatous mediastinal germ cell tumor. In treatment of germinoma, that is primary cranial germ cell tumor, you give intraventricular radiation. Okay, it's an extra question that can be asked. Non-germinomatous tumors, you give chemotherapy followed by intraventricular radiation or CSI if the CSF is positive. So that is, I think that pretty much covers everything that can be asked in germ cell tumors. Of course, you might get a bouncer here or there. Study all these things and you will perform really well in the exam, especially if you get GCT. Okay. So hope you had a good session. Thank you, Dr. Ronak, and hope you all
Yeah,
got
thank
a
you, sir.
good day. Good night.
Thank you, sir.
Yeah.